Hello, everyone. So I know you've just completed a pre-assessment quiz on diabetes and insulin, but this lecture is going to go into more detail about the most common types of insulin. So the objectives for this lesson is that you guys will know the difference between type 1 and type 2 diabetes mellitus, that you will know what the most common types of insulin are and understand the pharmacology of each of these types of insulin, and that you will also know the various available methods for insulin administration. At the conclusion of this lesson, you will be aware of the different educational factors that diabetic patients should receive to start the process of learning how to effectively manage their diabetes at home. So the American Association of Diabetes recognizes four clinical classifications of diabetes: type 1 and type 2, gestational diabetes, and diabetes caused by genetic defects or medications. But in this presentation, I'm only going to focus on type 1 and type 2 diabetes. So in type 1 diabetes, this is a chronic autoimmune disease that can sometimes be genetically inherited, causing the body to stop producing insulin, which is a hormone secreted by beta cells from the pancreas necessary for the uptake of glucose from the bloodstream and into the body cells for energy. So when we eat, carbohydrates are broken down into glucose. But without insulin, the body's glucose level will simply increase, which will lead to life-threatening ketoacidosis. While in type 2 diabetes, this is also a chronic condition which is acquired due to the body's inability to use insulin effectively, called insulin resistance, or there may be a lack of sufficient insulin secreting. A combination of factors, including lack of physical activity, being overweight, genetic predisposition, age over 65 years old, and poor diet can all contribute to the incidence of type 2 diabetes. So let's look at some differences between type 1 and type 2 diabetes. Type 1 diabetics need exogenous insulin administration that must be given subcutaneously to replace the absence of insulin secretion that the body's pancreas no longer produces. Insulin must be given to control hyperglycemia, avoid ketoacidosis, and maintain glycosylated hemoglobin A1C. Those with type 2 can use a combination of diet, exercise, oral medication, and/or insulin injections to control their blood glucose. The key here is to perform blood glucose checks regularly before meals, at bedtime, when sick, or if signs and symptoms of hypo or hyperglycemia develop. So let's quickly review the normal physiology of insulin in our bodies. So there's this constant release of beta cell secretion that maintains low basal levels of circulating insulin, which prevents the breakdown of fats, the breakdown of protein, and the breakdown of glycogen. So after we start eating, a burst of insulin secretion occurs as a response to an increase in circulating glucose and amino acids. This can last up to 15 minutes, followed by a postprandial secretion of insulin to regulate glucose levels in the body. Now, if our body doesn't do this naturally, we may need insulin therapy. So, according to the 2017 National Diabetes Statistics Report from the Centers for Disease Control and Prevention, 30.3 million Americans have this disease, and yet almost 1 in 4 people with diabetes are undiagnosed. Type 1 is more commonly diagnosed in children and teens and makes up about 5 to 10% of all diabetes cases, compared with type 2, which accounts for 90 to 95% of all diagnosed cases. So there are three main types of insulin. These include the fast-acting, intermediate-acting, and the long-acting insulins. So the fast-acting insulin, such as insulin aspart, lispro, or glulisine, work quickly, mimicking the mealtime release of insulin and control postprandial glucose. The onset of action is less than 15 minutes, with a peak effect in 1 to 2 hours, and a duration of action of 4 to 6 hours. An intermediate-acting insulin, such as NPH, which is used to control glucose levels overnight while fasting and between meals. This type of insulin has a cloudy appearance and is the only type of insulin that should be cloudy. The onset of action is 1 to 2 hours with a peak effect of 4 to 6 hours and a duration of action of more than 12 hours. Long-acting insulin, such as insulin glargine or detamir, works slowly over an extended period of time with a minimal to no peak effect to control glucose levels at bedtime and between meals. The onset effect is 1.5 to 2 hours. It then plateaus in the next few hours and has a flat duration of 12 to 24 hours for insulin detamir and glargine, respectively. So I've included a table of insulin action, including the three main types of insulin we've discussed, as well as their onset, peak, and duration times. I do expect you all to memorize this chart. So as nurses, we must be aware of the modes of insulin administration. Insulin can be administered using one of the following methods: a vial and a syringe, an insulin pen, or an insulin pump. In the United States, these methods of administration only come in concentrations of 100 units of insulin per 1 milliliter of volume, or you may see it written as U100. So there are definitely some safety concerns with insulin. The most common adverse reaction to insulin is hypoglycemia, which for children and adults would be less than 70 milligrams per deciliter, which may be very dangerous and must be treated and corrected. So all patients on insulin should be taught how to do this. Another concern is weight gain. Local injection site reactions can occur, such as the development of scar tissue, and the importance of rotating injection sites can help avoid lipodystrophy, which is a maldistribution of fat tissue in the body. So as nurses, we should be aware of insulin dosing. So I've included some calculations about how to get the total daily insulin requirements for a patient and how to estimate the amount of units a patient on long-acting insulin should be on. So as patients become more familiar with their insulin administration, their endocrinologist might teach them how to do carb counting. So carb counting is basically taking the total grams of carbohydrates in your meal and dividing it by the grams of carbohydrates disposed by 1 unit of insulin. So in the hospital, for example, we say that 15 grams of carbs is equivalent to 1 unit of insulin. So for example, let's say a patient had a meal that totaled about approximately 60 grams of carbohydrates. So you would then divide that amount by 15, which would equal 4, and that would be the amount of units of insulin that would help that patient cover that meal. I've also included the high blood sugar concentration dose and how to calculate that, as well as the correction factor. So you can see insulin is very expensive. For example, Humalog's list price is roughly about $325 for a 10 milliliter vial, while Lispro is around $200 for a vial, and Humalog's generic is priced at around $170 per a 10 milliliter vial. And on top of that, you need to add the price of syringes. Insulin pens are even more expensive, and a box of 5 insulin pens, 5 Humalog insulin pens can cost over $600, while generic can run over $300. The cost of Lispro can vary, but it runs about $150 for 5 3 milliliter pre-filled insulin pens. So when insulin is used appropriately and at the right dosages, the expected outcome is that adequate management will lead to control of blood glucose. So our goal must be to help reduce the complications of having diabetes, which can lead to blindness, neuropathy, slowed wound healing, limb amputation, nephropathy, and even cardiovascular disease. So it's very important that we remind the patients to be compliant about their medication regimen and to remind them to monitor their glucose levels regularly and to follow up with their endocrinologist as recommended. So here are my references, and I hope you've enjoyed this presentation on insulin.